So, okay, thank you so much, Maestro, for this invitation. And hi, everybody. 1 second, actually, 1 second. Okay. So, good afternoon, everybody, and thank you for the invitation. So, I'm going to talk about a very small topic, but the presentation is mainly aimed for residents, junior faculty who is preparing the exam, and this is advanced in skin cancer management. So, I don't have any disclosure, and I will be reviewing the emerging treatment for these common skin cancers. So the common skin cancers we are going to touch is actually melanoma, squamous cell carcinoma, and Merkel cell carcinoma. So Merkel cell carcinoma is a primary neuroendocrine malignancy and is very aggressive cancer. It typically occurs in elderly population, and in North America, the incidence is about 1 to 2%. I don't know what's the incidence in Middle Eastern countries, but very aggressive, and you need immediate management, otherwise it can become more aggressive. So these are the 3 cases I've seen recently, like last month in my clinic. You can see there is a erythematous papule. That's the typical presentation. It's a T1 lesion. And this is another one, a 3x3 in the forearm. And the third one is a young gentleman presented with an inoperable Merkel cell. So traditionally, patients used to go for just surgery followed by adjuvant radiation, but now the more stabilization in the treatment plan. So currently, all the patients should go for a primary biopsy, sentinel lymph node biopsy, then excision of the tumor, plus all patients should have a mandatory PET study. Now, there is no randomized study for Merkel cell carcinoma because of the rarity of the cancer. However, this is a meta-analysis published from Green Journal reported that actually overall survival and disease-free survival are improved with adjuvant radiation treatment. But the study also noticed that the adjuvant radiation won't improve the distant disease-free survival. So distant mets, about 30% of patients in stage 1 patient, stage 3 patients will have metastatic disease. Now, this is our own data. This is also one of the largest series, and we also noticed that patient with stage 1 or stage 1, 2, and 3 benefit from radiation. However, we also noticed that patients with stage 1, we could avoid radiation provided the risk factors are not there. For example, sentinel lymph node biopsy negative, no associated high risk factors, lymphovascular, like a lymphovascular immunosuppression clay margin. We also noticed that the adjuvant radiation won't help for distant mets. Now, this is a very important publication from the Seattle group, Paul Neum. They used Pembro for patients with Merkel cell carcinoma. It's about 26 patients, but it was a sort of practice changing. So after publication, many physicians, many centers, they use Merkel cell with advanced disease stage, like a stage 3. They will offer Pembro. So in summary, patients with the Merkel cell carcinoma, they go for wide excision of the primary with 1 to 2 centimeter clear margin, sentinel lymph node biopsy, PET imaging, and you could avoid RT for early stage like T1 disease. Whereas if node positive cases, all patients should go for complete lymph node dissection and RT to the primary and regional nodes. Inoperable cases, at the moment, the practice is patient will be treated with etoposide and plantain, like a small regimen, and then you add radiation along with it. So it's a chemo radiation, and then patient might be considered for surgery depending upon the response. And so that is in short the the summary of Merkel cell carcinoma. Then regarding radiation, typical radiation dose is 50 gray, 25 fractions over 5 weeks. And microscopic disease, you can go for a higher dose up to 60 gray. And then if R2 or still a residual tumor, you need to go for a higher dose. Now, moving to malignant melanoma, the treatment used to be radiation, chemotherapy as an adjuvant, but that was the old story now. Now, all the patients after excision and up from T1 onwards go for adjuvant immunotherapy. And again, here also you need a wide margin, if possible, minimum, if possible 3 centimeter, but head and neck region you cannot do. So that are cases sometimes positive margin could be considered for radiation. But generally, immunotherapy is the adjuvant standard treatment, and the URTC study shows ipilimumab is better than high-dose interferon. And also the Keynote 54 or Checkmate studies, they both confirmed the benefit of immunotherapy for patients with as an adjuvant treatment for melanoma. Now, the question about radiation treatment, there was one Australian study, the TROC study, and didn't show any benefit in terms of overall survival. It improved the local control. So at the moment, radiation, there is no role. So at the moment, after the treatment, there are multiple single institutional data reported, higher incidence of local recurrence. However, there is no evidence to use adjuvant radiation for this setup because no level 3 evidence. And having said that, as mentioned before, some centers are using radiation for extracapsular extension or high burden of positive lymph nodes. Now, there's an emerging data combining immunotherapy and radiation. This is our own data from, Mo Mohanath is one of our, was a resident. He's a radiation oncologist currently from Saudi Arabia. And he looked into the data of patients. We used to give, for metastatic disease with the oligomets, we give actually weekly radiation along with immunotherapy, 30 to 36 gray in 5 to 6 fractions. And this is an emerging data for the management of metastatic melanoma. Now, moving to squamous cell carcinoma, again, small squamous cell carcinoma, you can treat with radiation, surgery, Mohs surgery, or cryo. Whereas if it is a locally advanced, that's an issue. So if you do surgery, then you cannot get a significant benefit without significant morbidity. Other options are tried are chemoradiation or radiation alone. And chemoradiation, this is an extrapolation of evidence from head and neck area. But the efficiency data is limited. And local radiation alone is about 60% is the local control. This is the chemoradiation study from Australia. Again, it didn't show any benefit in terms of disease survival or overall survival. Radiation alone this is the BC data from Winkelkorn, and then they found actually 58% is the 4-year local regional control. And this is from the Florida group, actually, they found actually about 50. So 50 to 60% local control with radiation alone for locally advanced squamous cell carcinoma. However, the recent data from Migden, and this is actually, I think, now this is a practice change using cemiplimab for patients with cutaneous squamous cell carcinoma. Now, the Empower study presented, and one of the group was actually patients with locally advanced squamous cell carcinoma. And they used cemiplimab 350 milligram 3 weekly, and that's what they used. And they found that actually 45% was the overall response rate. And then 10% was actually complete response, and then partial response 25%. So this is the now a common practice in North America using cemiplimab for locally advanced squamous cell carcinoma. The study showed overall survival, but no difference in progression-free survival. Now, there are a few cases. So this is the gentleman, and he is actually a very elderly gentleman. He was actually having this squamous cell carcinoma. You can see the lesion, and initially he was offered radiation, but unfortunately, after radiation, the disease recurred. It's become more, and then it was started on cemiplimab. So received 8 treatments and then stopped. You can see the big difference actually. So tolerated very well, have a great response here, both nodal disease and scalp. And this, so you can found that actually people who fail radiation or as a first line, nowadays people are using cemiplimab. Now, this is our own data. One of our patient, 82-year-old gentleman, and he was actually, because of the locally advanced inoperable squamous cell carcinoma, we started cemiplimab and we gave 3 doses. However, the response was not great. So we were thinking what to do next. So looking into the evidence, we can found that actually radiotherapy induces upregulation of the PD-L1 in tumor microenvironment. So combining radiation with PD-L1 inhibitors, it can cause a synergism and a significant tumor response. So this is what happened. We actually added immunotherapy, patient on while immunotherapy, we added radiation. So this is like, you can see the journey through radiation, the initial part, then 2 weeks after radiation, but then these 3 months, he's back to normal. He received 63 gray in 30 fractions with immunotherapy. Now, subsequently, patient underwent a PET study shows, this is the initial PET, and then this is the post-treatment PET. You can see there is still residual uptake. So patient went for radical surgery and found that there's no tumor. So my point is actually, if you look at the data, initial cemiplimab data, the overall response rate was 45%. Radiation alone was.
You have 1 minute.
Radiation alone was showing the response rate was about 60%. So in a situation, if benefit is not there from cemiplimab, you can add radiation. And of course, that's one other thing. And we have a case series we published actually about 15 patients we treated with a performance status 0 to 1. And they found actually significant benefit. So that's about my talk. And this is just about Cross Cancer Institute. I'm sure a few of you are familiar with this place. And also, because of the residents, as per Nadeem, Dr. Parvez discussed, I just want to update, we have a book also coming on radiotherapy in skin cancer. This is meant for residents, junior faculty taking board exam in UK or Canada. That's the aim. Thank you so much.